Just kidding. So we officially started this podcast. This is we're calling this the SAX Industry Vitals podcast, which is a very creative name thought up by my crack marketing staff. I want to thank them in advance for putting that together. I actually had a joke, not a joke, but did you know why people do that smack thing before cameras start rolling? No. This has nothing to do with what we're talking to today, but...
Not to replace the action?
Yeah, but do you know why people do that? The clapper, as it's referred to. No, so funny story. In editing video content, audio content, etc., when you line up the audio channel, because it's recorded as two separate channels, when you line up the audio and the video, it's really hard to get the voice to line up. You ever see like a bad dub where someone's talking and the voice isn't moving at the same speed? The snap puts a spike on the audio channel, and they use that spike to line up the audio channel to the video channel. And that's how they get the voice to sing. Oh. Anyway, you learn something new every day.
Definitely.
On the SAX Industry Vitals podcast.
We may have just peaked in content with the clap. We're already now.
I'll tell you,
I hope it's uphill from here.
I was going to say it's only downhill from there, but anyway, I wanna tee this up as the first ever SAX Industry Vitals podcast, and I want to introduce the players that are on this game. So my name is Leon Grassi. I'm the Chief Marketing Officer and Head of Business Development here at SAX LLP. And for the purposes of this conversation, I'm really just an MC. This is not obviously my expertise as far as the background goes, but what we're hoping to do is provide some educational content to our marketplace, to our clients in the healthcare space. We have many of them. And basically just give them some inside information featuring some guest speakers, of which there is one right next to me, and I'll give him a minute to introduce yourself. But we'll bring in those guests to talk about what's going on in the marketplace, and healthcare has been crazy the last few years and probably will only get worse before it gets better. So we're hoping that we can shed some light on some of these things and hopefully be moderately entertaining in the process. No pressure there, Brian.
Do my best.
So without further ado, I'm going to read your name off of here so I don't screw it up, although it's not a difficult name. Mr. Brian S. Kern, Esquire. Was I supposed to include the Esquire? Is that by law?
The Esquire. Of counsel at a health law firm. The joke is I have billed an hour for this firm, so I'm an official attorney. That's pretty much the only hour I've ever billed. I've done some pro bono stuff. But my main position is as a partner in a medical malpractice insurance brokerage called Acadia Professional, based in Morristown, New Jersey, but we are national in scope. And then I do quite a bit of healthcare consulting, very much related to payment reform, if that's what you want to call it. But there's been a big shift from fee-for-service to value-based care, whatever value-based care even means. But the whole idea is if physicians are able to reduce the cost of healthcare for their patients, how do we incent them to do that? So, some of that money goes back to the physicians. That will give them the incentive to do a better job of managing where they're getting their, testing done, whether they're going to the hospital, just trying to get them the most site-appropriate care.
I love it. And it's funny because every time we talk to you, I'm making this as a joke, Brian, but it seems like there's another business that you're involved in every time we connect. You do a lot in the healthcare space, right? So there's the one you get paid to do, and then there's all the other consulting things. I mean, let's be honest, you get paid to do them all, but I think that we're really excited and lucky to have you as our first guest here because of your history and your exposure in the healthcare industry. So this is exciting for us.
Well, the fun part is the networking and just being around great professionals like Debbie and like really the best MC that I've ever heard, Joe Rogan included, is like, right here. How often do you get to do stuff like this?
Warm up the Emmy. Is there an Emmy for podcasting? What is there's got to be a... Anyway, so Debbie, he already mentioned you. Why don't you give us your brief intro, if you don't mind?
Hi, yes. Debbie Nappi. I'm the partner in charge of our healthcare practice here at SAX LLP. I've been with the firm for many years. And I am so excited to welcome Brian today as our first guest. I've known Brian in many social settings as well as our healthcare related clients. And I always say whenever someone meets him, he is the person to know. Like Brian knows everyone, runs in many different aspects of healthcare. He's been instrumental in helping a lot of my clients and really looking forward to our conversation for today.
Awesome. I appreciate that, Debbie. And we're just going to dive in. I don't really want to waste too much time here. And we met in advance and put together some topics that we might want to discuss today. But I'm curious, just asking you both right off the bat, is there something happening right now that that our clients should know about, or we should be focused on from a healthcare perspective?
So there's just so much happening right now in terms of healthcare and where it's going, and Medicare Advantage overtaking Medicare as, basically the biggest group of payers.
Yeah.
And physicians have been trying to understand, how do they work with their payers? We always think of Horizon, Blue Cross Blue Shield, Aetna, Humana. How do we just get more money because we're doing all this work? We feel like we're underpaid. And then this concept of value-based care came out as I was explaining. So physicians think, well, if I could just help my patients get more cost-effective care, then maybe I could do better there. But the market, in a lot of ways, has been hijacked because Medicare Advantage gets reimbursed based on their overall population. And the sicker the population, the more money they get, right? So if you're treating a really healthy population, you're not going to get as much money as if you're treating a really sick population. But people kind of realized through billing and through tech, they could demonstrate that their patients are really sick, even if maybe the chart and the patient visits don't support that. So there was this huge rush to try to justify that you have the sickest patients and bill as many codes as you can, comorbidities within
Right.
that code, and it was a whole art to it. So the government finally, after paying probably 12 or so billion dollars more than they should have, finally came in and said we have to cap how much people are able to increase their overall benchmarks just through risk adjustment. So that's changing the whole landscape. But in the medical malpractice, I know the med mal insurance world is not all that exciting, but the so-called jackpot jury awards, the nuclear verdicts, whatever you want to call them, those are really the big issues in healthcare, in
Yeah.
medical malpractice right now.
Let's take a second to go back to the value-based care. Are there detractors to value-based care at this point? What's the future look like for value-based care, like short term, long term?
Well, if you look at pockets of expense,
Yeah.
this is not necessarily to pick on hospitals or the drug companies, but value-based care is a lot about keeping patients out of the hospital.
Mm-hmm.
So if you're a hospital running a value-based care program, it makes it kind of tricky.
It's a little
So
counterintuitive.
Right.
what's
Right.
the strategy for
Yeah.
us making less money and succeeding in value-based care? So the hospital's focus hasn't really been as much about value-based care as it has been keeping all of their patients within their system and called preventing leakage. So that's a way that they could use their data, and if they're able to reduce the overall cost of care, so maybe they lose whatever, just making it up 10% in
Yeah.
what they're being reimbursed, but they've just pulled in an extra 25% because they're doing the procedures and they're using their own specialists and everyone's going within their own system, so they're able to make it up that way.
Sure.
The drug side we could talk about for a really long time.
Yeah,
It's super
yeah.
complicated, but it's very hard to get inexpensive drugs. There are a lot of middlemen, the PBMs, the manufacturers, the those that are getting rebates and everything in between. So drugs and hospitalizations are the two really big areas. But then of course when you look to the physicians, utilization,
Right.
site of service, and just whether certain procedures are necessary, and if they are, how do you do post-acute? Can you get the patients back to work? Can you get them healthy? So there's a lot of moving parts. The data has gotten much better, so you
Right.
can manage these programs, but the incentives, the risk adjustment was considered the most lucrative area. The
Right.
incentive
So-
for the hospital to reduce hospitalizations, it makes it tricky.
No, I was going to say, maybe you want to explain to us like risk adjustment to our audience.
Yeah, so the sicker your patients are, the more money you make. So that's the whole notion behind risk adjustment. If you can bill a lot of comorbidities with your patients, your benchmark, the amount of money you get for treating that population, is going to be adjusted. So it's adjusted based on the amount of risk.
But now the new regulations, or what the CMS is trying to curb, so to speak, how is that affecting that? You said there's a cap now as to what they can bill for these risk adjustments?
Right. So the whole art was, it even comes down to the way you stack the comorbidities.
Right.
So if
Mhm.
you have heart conditions and
Diabetes,
pulmonary conditions,
right.
diabetes, and you can list them all in a certain way. That's how you maximize your reimbursement. It's called HCC, hierarchical condition categories, just to keep it really confusing.
Oof.
But that's the whole notion of risk adjustment. The more you code these comorbidities, and if you do it a certain way, the more money you make. So give me a patient population, I will send my AI out and I will talk to our teams and make sure we're maximizing this coding as best we can.
Mm-hmm.
And what started as a $100 million benchmark may now be a $110 million benchmark. And obviously these numbers can get much bigger. CMS, in a variety of ways for ACOs and now on Medicare Advantage, is capping the amount you can adjust this risk at 3%. So you'll notice a lot of Medicare Advantage players are saying, ooh, healthcare costs are really going up right now. Are they, or have you just kind of raised the benchmark and not really focused on how to reduce the cost of care? Because value-based care, by definition, is about trying to reduce the cost of care, not trying to make more money because your
Of the
patients are sicker.
Right.
It's okay, we have this group of patients, how do we reduce the cost of care?
Man, I am. This is tricky for me because I'm a relative Luddite when it comes to understanding the hospital healthcare system, but I'm also, as an objective patient, which I guess is where the category I fall into here. What does this mean for patient care at the end of the day, right? Should I be, all this stuff is happening behind the scenes, so I mean, what should I be thinking about all this, or do I care
Well,
as a patient?
as we probably all know, the best person you could have through a healthcare journey is a physician on the inside, a nurse on the inside, and that's kind of the whole notion of population health. How do we help all patients throughout their care journeys without being best friends with your primary care physician or having a nurse in your family? So the idea is to equip the primary care practices with the data that shows what's happening to their patients after they leave. So the 15 minutes, the 30 minutes I spend with my primary care provider every year doesn't give them the picture of whether I injured myself doing jujitsu or whether I developed some kind of condition that drove me to the emergency room. We want to make sure our physicians, the primary care physicians, have access to all this information so that they can make the appropriate recommendations, what drugs I'm on, so they can manage that process. And that wasn't available only a few years ago. So part of this idea of value-based care is getting the data that the physicians want and need to provide the best care. And of course, that's opened up the door to a lot of other factors. But I think in its essence, that's what we're trying to do. Identify the patients that need the most care and deploy the right resources to those patients.
So now the pivot in this conversation is to somewhere where I am comfortable, right? Okay. So more than half of my 21 or some odd year career has been in the technology industry. So I'm listening to what you're saying, and I'm hearing a lot of the buzzwords that we're talking about just in the world of business consulting as a firm, as ourselves. And technology is obviously going to have a huge impact on all of this. It's going to probably make value-based care possible, right, theoretically, because it's that access to the data that you never had before that's going to change the process. So, what is your very high-level opinion of how technology is impacting healthcare? And a caveat to that is healthcare has always been at the forefront when it comes to technology, right? Generally speaking, they are early adopters, large scale, on a lot of the infrastructure-based technology that have been out there because of the massive amounts of data and the high levels of compliance and all that stuff. But what does this mean? What do you think technology means to the space as we move forward? Is it a good thing? Is it a bad? Is it making it harder for you? What does that look like?
So first and foremost, it's about the data. And you have to get access to.
By the way, I'm a data guy. You're a data guy.
I'm a data guy.
Are you a Jersey boy?
I may end up switching data and data. You've committed yourself to.
I'm data.
You've committed yourself to data. I may go back and forth. I have commitment issues.
Debbie, are you data or data?
I'm data.
Okay, so you have to think about it. Yeah. Okay. All right.
I think I'm a data guy.
Are you Park Roll or Taylor Ham?
Well, obviously Taylor Ham. I live in New Jersey.
Obviously. Okay. So anyway.
So the data is the key to the whole equation, right? Garbage in, garbage out, depending on what you're trying to build, algorithms and all that. But once you have the data, then it comes to, all right, how do we provide better care? And that's a really broad term. So
Yeah.
can we provide telemedicine support for some patients who don't have great access to physicians? Maybe the line is too long to get into the actual office, but we can schedule them. Behavioral health is a great example, right?
Yeah.
Or we can schedule them for these calls just to get their meds refilled.
Right. Right.
And behavioral health has sort of set the precedent already, right? It's a widely adapted at this point use,
Definitely.
right?
And even there was a change within, I don't know if it was in the last 6 months, as far as the billing,
Mm.
right? Whereby now they have the ability to cross state lines.
Oh, okay.
Yeah, for mental health, right? Because there's
Sure.
such a big push.
And we're getting much better at treating the symptoms. We have to do a better job of now using the technology and using the access to healthcare to slow the spend. So behavioral health is a perfect example. If you looked at the frequent flyers, as they're called, the
Yep.
patients that are showing up at the emergency room the most, many have associated behavioral health
Right,
problems.
right.
It's not necessarily that
Interesting.
one thing that's bothering them. You know, their knee hurts or they have chest pains.
Mm-hmm.
They've already been cleared. They don't have any kind of, acute cardiac conditions, but they have behavioral health problems, whatever that might mean, right?
Mhm.
They need companionship, so they show up at the emergency room, where they feel like they need health care and they don't. It's just hypochondria type of situation.
Yeah.
So if we're giving them access to regular behavioral health, can we make sure that those patients aren't going to the hospital? And codes for behavioral health, the reimbursement for behavioral health isn't that great. So that's
Yep.
where this tech piece comes in to say, here's a group of patients that are costing the system millions of dollars every
Mhm.
year. We're going to give it to this behavioral health company, and they're going to stay in touch with these patients and hopefully keep them from going to the emergency
Right.
room. And if you save $3 million, you get $1.5 million in the shared savings.
Sure.
So that's what may come back to this behavioral health company, but that has to pull together the data analytics and so many other pieces,
Sure,
the tech
yeah.
and the workflow and the sales piece. And like hospital and home is another great example of
Yeah.
technology marrying healthcare and trying to be able to
But
deploy
I
those
have a
resources.
question in all this. We always hear about price transparency, right?
My
And how
favorite topic.
Yes.
Do you want to
And-
send him down this path, Deb?
I do. But just how it's available,
Yeah.
right? The hospitals were supposed to pose so many years ago. Some did, some didn't. But just how patients, right? The big concern that inpatient health, they were going to go and they were going to be the consumer because they were going to have the ability to shop
Mhm.
different physicians and prices. But have you really seen that there really is true price transparency for
Well-
patients to really be able to have this information
Right.
available?
So first and foremost, there is not price transparency. There are files that are available
Yeah.
that tech companies or companies that have built the right crawlers
Mhm.
and have the data analytics behind it can pull these files. For the most part, hospitals have not complied. The penalties are not very stiff. They've made a business judgment to say we'd rather just pay the fines than
Right,
to deal
right.
with this price transparency, because once everyone realizes that you could get this procedure down the street for
Right.
half the price, that's not good for us. So we don't want that getting out. And if we have to pay pennies on the dollar in fines versus what business we're going to lose,
Right.
then that's a business judgment. For the payers have to report all of their reimbursement rates to every single physician, and there's hefty fines. These commercial payers do have to comply, but great example, one payer decided the best way to comply is to post everything. So they're going to give all their reimbursement rates, but they're going to put it into a single file.
Okay.
So if your computer can process 12 billion lines, good luck, you have price transparency. For everyone else in the world, you need to find a company that is going to be able to compute all this data and then charge you a
Well,
hefty sum.
but having said that, we're on the verge of that type of computing power to be available to the general public, right? That's what artificial intelligence is essentially doing for us in a very short term. So it's a very interesting outcome that could come of that.
So to talk monetarily,
Yeah.
it's probably going to cost you $250,000 to
Yeah.
work with a company to get the reports you need to
Yeah.
really take advantage of price transparency.
Yeah,
That cost will come down and down and down.
sure.
Of course, we could just enforce the rules and say, no, you have to put this data into a usable format so
Right.
everyone has access to it. And then that would really start to change behavior. But self-insured employers are all over it. And
What-
anyone who should be controlling healthcare costs.
What
are trying
effect
to use-
does price transparency have on patient quality of patient care? Does that become now a commoditized offering where people are racing to the bottom on pricing? Like, is that? And I joke because I remember years and years ago when I was on the subway when LASIK first became a thing, and there was like advertisements in the subway where it's like, you pay for your left eye, you get the right eye for free. I'm thinking to myself, this is ridiculous. Like,
Is that where you want to skip care?
yeah, it's like, do I really, my vision, do I really want to
Right.
cut it? But I mean, I'm being a little bit facetious, but does it diminish quality of care?
We look at two factors. One is quality metrics, and
Yeah.
that's a whole conversation that we'll get to in a second, and the other is price.
Yeah.
So if we know that the outcomes are as good or better at a location down the street from a hospital and
Sure.
it's half the price, then absolutely 100%. It's much trickier when you're trying to compare physician to physician. A
Mhm.
big fee-for-service strategy, as everyone knows, I think, is consolidate physicians, get some private equity money to help assist in that process, and then go back to the payers and negotiate higher rates. Now, that in and of itself is not good for patient care, it's just raising the rates. The companies that we like in this space are the ones that have built a good infrastructure, are making patient care better, are focused on outcomes, and are helping patients navigate the continuum of care. So if I'm an orthopedic surgeon and I charge a little bit more, but my hospitalization rates are significantly less, then that's easy to justify going to that physician, right? Great outcomes, very,
Sure.
very low post-acute care costs, but I'm going to charge more. And I think it's worth it for that, right?
Makes
I'm not
sense.
going to go to
Yeah.
the cheapest LASIK surgeon without knowing anything more about him. But if I find out that she has the best outcomes and
yeah.
everyone's 20/20 vision coming out, then absolutely I want my left eye free.
2 for 1, two
Well,
for 1 blockage. You know, hard.
I think except for the New
Man.
York market where everything is pretty much still
Yeah.
driven by the patients paying for their visits, I think patients more so now are so concerned about their deductibles and
Sure.
their out-of-pocket costs and navigating who's in their plan. So I think they're more aware of that because financially they're expected to contribute more than they've ever had to in the past.
And
Yeah.
I was going to say, and my question to caveat or to piggyback on that, Brian, is that we're talking a lot about the quality of patient care. Let's talk directly to our clients, right? The folks that will be listening to this. And what do you believe they should be doing as it pertains to price transparency and value-based care? What should their focus be right now? Where should they be investing their time, money, and educational efforts?
Well, starting by compiling their own data by any means necessary. And it could mean going out and paying to understand what others are gathering on you. But
Yep.
it starts within your own EHR, understand what your patient demographic looks like, and do your best to try to figure out where
Sure.
your patients are going after they leave your office.
Do they know who to go to pay to get that done? Who those data experts are? Are they out there?
No, they probably don't, but they may have
Yeah.
good operation systems internally.
Well, don't keep them hanging. Do you know who these people are?
We do, yeah, of course.
So what you're saying is reach out to Brian Kern I'm serious. Like, that's something they should do, right? Because they don't know who to go to for that, right? That's a difficult resource to find.
Yeah, so that's what we try to do. We try to pull all of this outside data, patient satisfaction, quality metrics, and then figure out whether it's even meaningful or not. And we use that for their practice because it could serve both purposes. One,
Sure.
maybe they're entitled to higher reimbursement. They don't
Right.
even know it because
Sure.
this group down the street is making twice as much of that as them, and their outcomes aren't as good. So we can actually pull comparative data. Or for the ones that are the highest price right now, it's time to justify
Yeah.
your higher reimbursement rates because it's just a matter of time before price transparency really takes effect and these payers start to come back to the physicians and say, wait a minute, I'm sending you a lot of patients and you're costing me a lot more.
Sure.
If you're right there saying, yeah, you pay us a lot more, but you're saving millions on the back end because we're doing a much better job managing your patients, getting them back to work, keeping them out of the hospital. So it's a two-part process.
I have a question for that. So for smaller practices, right, who don't necessarily have the ability to aggregate data or data
Either.
either,
Either.
Either. Okay. Woo.
Potato. Anyway, yes.
How have you seen these smaller practices have the ability to aggregate this information, right?
So this is where I'll give myself a shameless plug, because working with us, we can pull that data for them. It's kind of just become a part of our normal process in engaging physicians. But the reality is, unless they all somehow find us and know which
Now,
questions
this is
to
on
ask,
your malpractice side?
we would do it for clients on our consulting side, or if
Okay.
they're med mal
Okay.
clients of ours. We do it for a lot of clients already. But that's part of the problem. If they can't access this information, if they're unable to justify or even try to negotiate higher reimbursement rates, someone's going to come to them
Sure.
and say, "You're making $100 for your 99213 office visit. We make 200. So if you join our practice, come
Yeah.
under our tax ID number, you're not going to get the full 100 because you have to pay us X amount of dollars to run the back office, but you're going to make more money, and we're going to take all of your headaches away. No more dealing with your own billing, no more dealing with your
Sure.
own."
Could be a very compelling story.
It is a very
Yeah.
compelling story, and it exacerbates the consolidation in healthcare when
Sure.
you're able to do that. But there is that counter force, which are the independent physicians that understand this game. And it doesn't mean they don't take private equity money. It doesn't mean they're not trying to grow, but they're able to demonstrate that they are providing high quality care. And those are the ones that are able to compete with these big
Right.
international or
Right.
you know,
Yeah.
national consolidators.
It's interesting, man. So here's the story for today's podcast, because I want to make sure that we stay brief enough to educate people and we don't go too long. So what I want to do is kind of put a little bit of a bow on this right now, and I'm going to ask both of you a very simple question. And my call to action for those listening is I'm going to go through the bullets that we actually had here, just so we try to stay within the confines of a specific time frame. But we Brian sent us bullets about obviously medical malpractice being a big part of what you understand and know in your background. There's jackpot jury awards was a bullet that we could have discussed today. Financial risks, and should doctors take a financial risk? How hospitals make money. We covered a little bit on price transparency. Obviously, we can go way down that rabbit hole, so to speak. Site neutrality was a bullet that was on here. Non-compete agreements. We talked about value-based care and risk adjustment. Which healthcare tech companies will survive? I love that one. We can have probably 5 podcasts dedicated to that. And then last but not least, around private equity, where I love how you phrase this, where will the smart and dumb money go next? So the reason I read those out is that if you're listening and any of those are resonating with you, then my call to action is to engage us, and let's have those conversations on a greater capacity. And I'm going to volunteer Brian here, and he may hate me for this, but he speaks a lot about this stuff, and there's a lot of events that he takes part in throughout the year where you can go and see him and meet him, and he's probably going to cover a lot of this in his presentations. And he also speaks on behalf of SAX as well. We've had him at our events too. So we'll have some contact information on the back end of this podcast for people to reach out and learn more on any of those subjects. But if we can put a bow on it today, at the risk of sounding like I want a major definitive from you today, Brian, what's like, you're sitting down with a client, what's the absolute first thing that you want to talk about with them these days, and what should they be focused on first?
Well, I think the
He's
key
smiling.
is
He's smiling. That makes me nervous.
this is why I have to do more than just medical malpractice insurance, because you didn't want to talk about it at all. So this is why I have to do all these other things, Leon. So people are interested in me.
I'm so sorry.
But I think we've kind of touched on it quite a bit. I think the most important thing that we try to convey to our clients is other parties are getting a tremendous amount of data on you. And we could show you what they're getting. We have it. We'll bring it with us. Yep. You could see it. We'll do it on a Zoom. But all of this information you've never seen. How are we able to get it? You don't think the Medicare Advantage plans and the self-insured employers and all the big payers out there have this same information and are looking at you the same way?
Sure.
So get it on yourself first. Understand what this is saying. And it's not always right. Back to garbage in, garbage out. Just because you have a bad Yelp or whatever all those Yelp-like apps are for healthcare, or you have one, there's so many individual circumstances that could throw off your metrics. So understand what's going behind these metrics, who's tracking them,
Yep.
and then use them to enhance your relationships
Use them to your
with
advantage.
the various
Yeah.
payers.
Yeah.
And so just to tie it all back to medical malpractice, because everyone's like, what does this ever have to do with what you do? We think that those that are following their patients, providing
Sure.
patient care, not just when they're going to the office or in the OR, but
Sure.
they're able to stay with their patients, keep them out of the hospital, recommend everyone who needs to be recommended. Those are the physicians that don't get sued.
Yep.
So for years, we've been trying to provide the resources, risk management resources, informed consent, post-acute care, population health. All of this, in our minds, is exactly what prevents a physician from being sued. So we're able to pull it all together in that nice, neat little bow that you
Well done. And I think that, again, having spent a lot of time in the technology service industry, I can tell you without a doubt that it's always been the companies that have access to data that succeed versus those that don't. And it's a worthy investment to make. So well done on you there. Deb, put a bow on it from your perspective.
You know, in the last few months, I've had many conversations, many meetings with my healthcare practices, and there's a lot of frustration, right? They're working hard. Like you said, there's technology needs, and the reimbursements continue to diminish, right? And in that, then they are seeking, what can I do differently, or can I have a transaction? And that's when I sit down with them and let them know that we do have resources like Brian, and we have reached out to his company to assist us with some of this data, right? So that they can see, how do they measure up to their peers? When they have this information, do they have a position whereby they could go back and renegotiate their contracts with the payers to give them a lift, right? To give them something, an incentive to keep continuing in what they've built, their legacy for all of these years. So I let them know that behind SAX, there stand so many healthcare consultants that we have relationships with, that we can bring them in to this discussion and assist them, so that we can then be their advisor, partner, and help them, so that they don't have to just make a quick decision that might not be the best decision.
Great call. Deb, I love that how you did that. And the truth is, on our side, on the, on the business consulting side, the truth of the matter is, it's always about having the right team. That's probably the most important variable, and I think that that's something that we can do on behalf of our clients. So I appreciate that from you both. I thank those that tuned in, and this is the first of many more to come. So hopefully we'll have you back. Not hopefully, we're going to have you back, Brian. I mean, you were an expensive resource for us here today, but I'm just...
Yeah, about that. I haven't got payment for this yet.
Thanks for tuning
Checks in the
in.
mail.
Really appreciate it.